What makes your heart keep time, move blood, and create the spike traces you see on an ECG? In the next 30 minutes, you'll understand exactly how blood flows through the heart, how valves work, and what an ECG is actually measuring. Let's begin. First, we'll map the heart and follow a drop of blood. Then we'll look at the valves and mechanics of contraction. Finally, we'll explain ECG basics and what common changes mean. I'll show diagrams and real ECGs along the way. The heart has 4 chambers, 2 atria on top, 2 ventricles below. The right side handles deoxygenated blood, the left side handles oxygenated blood. Blood returns from the body via the superior and inferior vena cava into the right atrium, goes to the right ventricle, and is pumped through the pulmonary artery to the lungs. Oxygenated blood returns via pulmonary veins into the left atrium, moves to the left ventricle, and is pumped out the aorta to the body. Drop starts in systemic veins, enters right atrium. Right atrium contracts, atrial systole. Tricuspid valve opens, drop enters right ventricle. Right ventricle contracts, ventricular systole. Tricuspid closes to prevent backflow. Pulmonary valve opens, drop goes into pulmonary artery to lungs. After gas exchange, drop returns via pulmonary veins to left atrium. Left atrium contracts, mitral, bicuspid valve opens. Drop enters left ventricle. Left ventricle contracts. Mitral valve closes. Aortic valve opens. Drop is ejected into aorta to supply systemic circulation. Valves are passive flaps that ensure one-way flow, driven by pressure differences. They don't actively open, pressure gradients do. AV valves, tricuspid, mitral, separate atria from ventricles and prevent retrograde flow during ventricular contraction. Semilunar valves, pulmonary, aortic, prevent backflow from arteries into ventricles after ejection. Valve closure produces heart sounds. S1, closure of AV valves at start of ventricular systole. S2, closure of semilunar valves at start of ventricular diastole. Isovolumetric contraction, ventricles contract with all valves closed, pressure rises, no volume change. Ejection, semilunar valves open, blood ejected, ventricular volume falls. Isovolumetric relaxation, ventricles relax, semilunar valves close, S2 sound. Filling, AV valves open, ventricles fill passively. Atrial contraction adds the final volume, atrial kick. Heart rhythm begins in the sinoatrial, SA node, the natural pacemaker. It fires, spreads through atria, causing atrial contraction. Signal reaches the AV node, which slows conduction to allow ventricular filling. From the AV node, the signal travels rapidly through the His-Purkinje system to coordinate fast, synchronous ventricular contraction from apex to base. An electrocardiogram measures electrical potential differences at the skin produced by depolarization and repolarization of the heart. P-wave, Nance atrial depolarization, atrial contraction follows. PR interval, Nance conduction time from atria through AV node to ventricles. QRS complex, Janker ventricular depolarization, large because ventricles have more muscle. ST segment, Janker early ventricular repolarization. Deviations indicate ischemia or injury. T-wave, Janker ventricular repolarization. QT interval, Ashaw's total time for ventricular depolarization and repolarization. Important for drug effects and arrhythmia risk. P-wave precedes atrial contraction. QRS precedes ventricular contraction. S1 aligns with QRS. S2 follows T-wave. Atrial fibrillation, chaotic atrial activity, irregular ventricular response. Increases stroke risk. Heart blocks, slowed or failed AV conduction, may require pacemaker if symptomatic. ST elevation indicates acute injury, MI, in the corresponding territory. ST depression can indicate ischemia. Recap: blood flows RA, RV, lungs, LA, LV, body. Valves ensure one-way flow and create S1, S2. Electrical system times contractions. ECG records that electrical activity and helps diagnose rhythm and ischemia. If you found this useful, like and subscribe for more physiology breakdowns. Links in the description include animated models, recommended textbooks, and ECG practice resources. Ask questions in the comments. I'll cover advanced ECG interpretations in a follow-up.